everyone. Welcome to the Test to PrEP webinar, bringing pre-exposure prophylaxis into your HIV testing strategy. My name is Oliver Bacon. I'm with the San Francisco Department of Public Health in our capacity building assistance for HIV prevention branch. I am also an HIV clinician and was a co-investigator on the PrEP demonstration project here in San Francisco. We also have sites in Washington, D.C. and Miami. I'm going to let the other co-presenters introduce themselves, starting with Thomas.
Good morning, good afternoon, everyone. My name is Thomas Noble, and I work here at the Department of Public Health in San Francisco in the Community Health Equity and Promotion branch. And my role primarily is working with community-based organizations that we fund for HIV and Hep C rapid testing with an element of QA and training and the nuts and bolts and all the logistics. And part of my role is to make sure they are as successful as possible in the work that they are doing. So that is me.
Okay, Melissa.
Hi, good afternoon. This is Melissa Morrison. I'm the HIV Prevention Director with the Tennessee Department of Health in Nashville, Tennessee. So that's all I have to say.
Excellent. And Megan?
Hello, everyone. My name is Megan Cannon, and I am the Program Coordinator here at the Houston Health Department, and I work in the HIV STD Prevention and Viral Hepatitis Bureau. And that's all.
All right, great. Thank you, everyone. So, before we get started, here's a poll question. We'd like to know what type of organization you work for. So you should be able to respond on your screen. There we go. Okay, the last few votes are coming in. So with 89% of the precincts reporting, we have 48% health department, 25% community-based organization, 15% healthcare organization, and 13% other. Great. Okay. So hopefully there will be something for everyone in the next hour. So some quick housekeeping rules. So if you have any questions during the webinar, type them in the chat box. And we'll see how many questions we have, and we may take questions along the way, or we may save them for afterwards. And please, 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 if you haven't already done so, please complete the HPAT. We're required to provide HPATs because we are a CDC-sponsored organization. If you haven't done so already, please do so via the link that's in the chat box. And if you've already done so, great, and sit back and enjoy the webinar. And finally, please be sure to complete the evaluation at the end of the webinar. We value your feedback very, very highly. Okay, so a quick introduction about our San Francisco Department of Public Health SEVA program. So we are funded by the CDC, thank you very much, CDC, to provide capacity building assistance in high-impact HIV prevention. That really breaks down into three areas for us. One is HIV testing, and that includes community-based testing, home testing, novel testing technologies, and partner services linkage. We also provide capacity building assistance in prevention for at-risk negative persons, really focusing on PrEP and PEP implementation, and also personalized cognitive counseling for episodic substance users. And then our final area of assistance is in policy, and that really includes data to support the HIV care continuum, harm reduction, jurisdictional planning, and working with cross-sector partners. We have a very collaborative approach for delivering capacity building assistance with peer-to-peer mentoring, site visits, providing resources and toolkits, fostering online learning communities, webinars such as this one, and live chat office hours, and we really emphasize a cooperative approach. Here's our contact information. So you can visit us at www.getsscba.org. You can call us at 415-437-6226, and you can email us as well. Okay, so we're going to talk about bringing PrEP into your HIV testing strategy. And here's a brief roadmap. We're going to talk about HIV testing in the PrEP care continuum, where HIV testing fits in. Some characteristics of commonly used HIV tests. As you all probably already know, there's a variety of testing types, and they each have their own characteristics and are useful for detecting HIV infection at various stages. How to incorporate PrEP evaluation and referral into a pre-existing HIV testing program. And particularly, Melissa's going to talk about an example of that involving a HIV testing program for young black men who have sex with men in Tennessee. And Megan Cannon is going to talk about PrEP and HIV testing in Houston, Texas. So a quick disclosure. So whatever we say here is not necessarily the policy of the San Francisco Health Department. And also, I may talk a little bit about the PrEP demonstration project to which Gilead, the drug company, donated medication that had no role in data collection or analysis. So starting with the PrEP care continuum. So this is a kind of a generic cartoon of what PrEP looks like from an implementation point of view. As you'll see, most of the activities involved with PrEP are very front-loaded. There's quick question. Okay, never mind. So as you can see, PrEP starts with a pretty fair amount of activity at the beginning. So there's an initial screening visit, and that involves a sexual risk assessment, basic medical history, an exam, really looking for symptoms of acute HIV infection, a lot of patient education about PrEP basics, how it works, the importance of adherence, what side effects, what few side effects they might expect, some baseline labs, HIV testing, testing for sexually transmitted infections, and safety labs, which really boils down to the renal function and hepatitis B virus status. And then often navigation services, provider clinic referrals as needed, financial case management. Traditionally, that's been followed by PrEP initiation visit 1 to 2 weeks later when the drug is actually started. Increasingly, though, programs are recognizing that people don't want to and probably shouldn't wait and are implementing same-day PrEP initiation where they do screening and initiation at the same visit. That's typically followed by follow-up visits, starting at 4 weeks and then every 3 months thereafter. And the follow-up visits are extremely straightforward. There's a symptom review, sexual risk assessment, counseling, follow-up HIV testing, testing for STIs, and testing for renal function. And it's really, really important to note that HIV testing is absolutely essential at the beginning of the PrEP process because what you really want to do is rule out acute HIV infection. Okay, so what about the characteristics of commonly used HIV tests? So here's a case to help focus you on the issue. So this is a 23-year-old HIV negative woman who just found out that her boyfriend has been having sex with other men from time to time. The boyfriend says he's clean, whatever that means. She has no other sexual partners, and she's conflicted about how to proceed with the relationship. She's on birth control, implantable birth control. She did have intercourse, unprotected intercourse, with his boyfriend last night. She's heard about this new PrEP thing, and she wants HIV testing. So what are you going to do? So this is what CDC recommends in terms of HIV testing for PrEP, and she is definitely an appropriate candidate for PrEP, and so needs baseline HIV testing. So this is what the CDC recommends. At the very least, you should document a non-reactive antibody test within 1 week prior to starting or restarting PrEP, and then every 3 months on PrEP. And that can be as simple as a lab-based antibody test, HIV antibody test on plasma, or it can be a rapid FDA-approved finger stick antibody test. It should not be the oral rapid antibody test. It should not be a self-reported test by the patient, and it should not be an anonymous test. You need to order a test, and you need to document the results yourself. Obviously, if this initial screening test is positive, the person needs confirmatory testing and referral for care. And if you suspect at their screening visit that someone could have acute HIV infection, then the CDC recommends that you delay starting PrEP and you send an RNA test to rule out acute infection. So just to reiterate, at the very least, an antibody test, a blood-based, whether it's whole blood, serum, or plasma, antibody test for HIV within 1 week before starting. These are, this is a summary slide looking at the most common features of acute HIV infection, the clinical signs and symptoms. So overall, the most common symptom of acute HIV infection is fever. Next most common is fatigue, and then muscle aches and pains, and then skin rash. And again, to reiterate, if someone presents with these symptoms, you probably want to delay PrEP initiation and really rule out acute HIV infection. There's one important caveat, which is that many people who have acute HIV infection don't manifest any of these symptoms. So the absence of these symptoms is not assurance that the person does not have acute HIV infection, but the presence of any of these symptoms should clue you in that it's a possibility. So these are the typical lab markers of HIV infection and when they appear after infection. So if you look all the way over to the left, day 0 is the time that someone is infected. The first test that will start to turn positive after that is in red here. It's the HIV RNA test in plasma. And you can see that it starts to turn positive 10 to 11 days after infection. The next most sensitive test for early HIV infection is the HIV-1P24 antigen test. That starts to turn positive 15 to 16 days after infection, so a little bit later than the RNA test, a little bit longer window period, but still pretty sensitive early on. The HIV antibody test starts to turn positive 3 to 4 weeks after infection, and that's in blue here. And then I just want to point out in the green, about halfway down the slide, the eclipse period refers to that period of time between infection and the earliest lab sign of HIV infection. Okay. So what about these various HIV testing methodologies? So the first test that ever existed was the lab-based antibody test. It's an indirect test of HIV infection. It detects antibody, your body's response to HIV, rather than particles of the virus or viral RNA. Typically, it was run as an enzyme immunoassay followed by a confirmatory test if the EIA was positive. People often refer to generations of antibody testing. The first generation were the earliest HIV antibody tests. Second generation were a little bit more sensitive. And the third generation antibody test, which is the most sensitive current antibody-only test, is what we're working with now. So traditionally, these enzyme immunoassays were followed by a confirmatory test, which for a long time consisted of the Western blot, or sometimes a second different enzyme immunoassay. It usually took a day at least between the time the blood was drawn and the test was read out, because these are lab-based tests. They were not point-of-care tests. So the blood had to be processed in a lab separate from the patient. So a major step forward was the arrival of the point-of-care rapid enzyme immunoassay in a self-contained testing kit that could be run off of a finger stick blood sample rather than venipuncture. And the timing typically was that someone would start their HIV counseling. They would get a finger stick for their blood, for their HIV test. While the test was being processed next door, which takes 15 to 20 minutes, they would finish their HIV counseling. If the test were negative, no further testing was required, and if positive, then additional blood would be drawn for confirmatory testing with a diagnosis of a preliminary positive HIV test. The patient would walk out of their testing visit with an answer, which from a public health perspective was a great leap forward, because one of the problems with the lab-based test is not everyone would come back for their test result. So with a rapid test, everyone knows what their result is. Shortly thereafter, an oral fluid test also became available, but is slightly less accurate than the finger stick test. And this is not plugging any particular rapid test, but this is just what a self-contained rapid HIV test looks like. You can see they tend to be self-contained in a little plastic apparatus. You can read the result within 10 to 15 minutes, depending on the precise test. And looking at the interpretation boxes at the bottom of the slide, there's a control line and a test line. The control line should always read positive. The test line will only read positive if it's a positive result. So what about acute infection? So we've already said that rapid HIV tests are not very good for detecting acute infection. Really, the two tests that are much better at that are the RNA test and the lab-based fourth-generation antigen antibody test using the P24 antigen. So what's the deal with detecting acute infection? Well, patients are antibody negative during acute HIV infection, and at the same time, they're highly infectious biologically. They have very high viral loads, and they're highly infectious behaviorally because they don't know they're HIV infected, and the same behaviors that allow them to acquire HIV also allow them to transmit HIV to their sexual partners. And we think that a substantial proportion of all HIV infections, new HIV infections, are thought to be acquired from a partner who himself or herself has acute HIV infection. And remember, I said earlier, acute infection is often asymptomatic. Okay? So here's the rub. Patients who have HIV infection, whether it's acute or chronic, need at least 3 drugs to suppress their virus and prevent their virus from acquiring resistance mutation. PrEP consists of 2 drugs. So the M-tricidabine tenofovir pill is actually 2 drugs co-formulated into 1. That seems to be sufficient when it's present in the body at high enough concentrations to prevent an exposure from turning into an infection. It is not sufficient for controlling HIV once someone has established infection, including acute infection. So if you give PrEP, just 2 drugs, to someone who has acute HIV infection and who doesn't know it, that can lead to the virus being able to select drug resistance mutations, and that will require more complicated drug therapy for that person's HIV down the line. Okay? So again, this is the same information I presented before, but in a slightly different graphic, looking at the time to positive test from acute infection required for various different testing methodologies. So you can see, looking over at the far left, the HIV RNA test starts to turn positive quickest, followed by the P24 antigen test, followed by the HIV antibody alone test. And you can see the approximate timing of symptoms coincides with the approximate timing of acute infection detected by P24 or HIV RNA. Okay, so what tests can detect acute infection? There's really 2 of them. The HIV RNA test, or viral load, that was originally developed to monitor HIV positive patients on therapy. It detects actual viral RNA. It's not an indirect test. It's not looking for antibody. It's looking for virus. It's usually reported out in a quantitative fashion, as in copies per milliliter, or qualitatively, either present or absent. It costs about $50 per test, plus the cost of the machine, plus the availability of trained technicians and a higher level lab. There's a cheaper version of RNA testing that involves pooling samples, and we'll talk about that in a sec. It's complicated but useful in high incidence, high test volume settings. So the other test that can detect acute infection is the P24 antigen antibody combination test, commonly referred to as the 4th generation test, and it uses a third-generation antibody test, which is the best antibody test we have, coupled with a test for the P24 antigen. Okay, so this is a viral load processing machine, just to illustrate the level of technical complexity we're talking about, and the trained technician there standing to the right. So this machine happens to process all the viral loads from southern Malawi. So this is pooling, RNA pooling technology, and not to belabor the point too much, but really pooling refers to taking a sample from all of the HIV tests that are run in a particular period of time, let's say a week, and then taking that subsample and combining all the subsamples into one pool, and then testing that one pooled sample for RNA. And if it's positive, which will happen a minority of the time because HIV infection is a relatively rare event, you know, most weeks that's the pooled sample will be negative. Every so often that pooled sample will be positive, and then you go back and you run the individual samples. And it's an enormous saving in terms of cost and time. But again, it's, the technique is somewhat complex, and it's only really worthwhile doing in places that test a lot of samples and may detect a number of acute HIV infections. So in San Francisco, at the Department of Public Health lab, we use an RNA pooling technique. Blood banks are really the place where RNA pooling is used routinely. This is some more about the P24 antigen test. If you look at the little alien virus cartoon in the lower left, you can see P24 is actually a capsular protein from the virus. The lab-based fourth-generation HIV test is faster and cheaper to run than the RNA test. It can be run on individual blood samples or multiple blood samples. It takes about 2 hours to run. It's fully automated in this machine down on the right. And really, the test looks for antibodies to HIV-1 to the GP160, broken down into 120 and 41 portions, HIV-2 antibodies, and antibodies to the P24 protein antigen. Okay, and it's a good enough test so that it's really changed the CDC recommendations for HIV testing nationwide. So instead of the first generation of HIV testing, which was an enzyme immunoassay followed by a confirmatory Western blot, the new CDC recommendations are starting with the fourth generation lab-based test that I just showed you. If it's negative, it's negative. If it's positive, you follow on with a separate antibody test that distinguishes HIV-1 from HIV-2. If that is positive, then someone is confirmed HIV infected. If the differentiation assay is negative, then you have kind of a discordant test result, and you would break the tie with a nucleic acid test, an RNA test. And if that's negative, then the person has a false positive HIV test. If that's positive, then they're adjudicated to having a true positive HIV test and a diagnosis of HIV infection. So, getting back to our patient, what HIV test would you like to use? Whether or not she needs PEP or PrEP, she needs HIV testing. We know that her last potential exposure was within 72 hours. Actually, it was within 24 hours because she had intercourse last night. Her source patient is of unknown HIV status, but definitely at risk, and she may be in an ongoing relationship with him. So these are, again, the approximate sensitivities of the various tests. Lab RNA starts turning positive within 11 days. The lab-based P24 antigen antibody test starts turning positive within 16 days. The antibody-only test within 22 days, and that includes, actually, the rapid fourth-generation test, also known as the Determine, which, although it looks for antigen antibody, is less sensitive than the lab-based antigen antibody test. So it has approximately the same sensitivity as the lab-based antibody test at 22 days, and then the rapid tests at 3 to 4 weeks. So using a rapid HIV antibody test, it's the fastest one, it's the cheapest one, it's the quickest one. It will be available in 20 minutes, but it has the longest window period. So you could miss acute infection. If you were to use a lab-based fourth-generation antigen antibody test, it has a much shorter window period, and the result is available later today. You could use pooled RNA or individual RNA. Those have the shortest window periods, but the results are in several days, and then the most expensive. So here's what we did. We started with a rapid finger stick antibody test just to see if that was positive. That would have changed the story right there. It was negative. And her blood was then sent for a lab-based fourth-generation antigen antibody test. That turned out to be negative. She was prescribed 3-drug post-exposure prophylaxis, which will last for 28 days. She's working on getting her boyfriend tested for HIV, and the plan is to transition her directly from PEP to PrEP if she's HIV negative on follow-up testing at the end of 28 days of PEP. All right, so that's enough of me. And now Thomas Noble is going to talk about integrating PrEP into HIV testing programs.
Alrighty, that was helpful, Oliver. So this is kind of a roadmap of how we rolled things out here in San Francisco with regards to getting PrEP moved into the community, more specifically around our HIV testing and other prevention efforts. So we started with community forums, which were really quite fascinating to watch how the community had a lot of interest around this prevention strategy and a lot of energy with regards to whether or not we should go forward with it. And I remember attending these, and at some point, the conversation kind of went from whether or not we should use PrEP to how do we access PrEP. And so if any of you are out there who have not actually started this process and started talking to the community about PrEP, look for that turning point. That'll actually give you a strong indication that the community is kind of ready to move forward with regards to accessing it versus having the conversation about whether or not it's actually for them. So then once that kind of happened, we started training our outreach workers and our test counselors. We created a product, 8-hour training that basically looked at the complexities of PrEP and how would you work with a client to help them assess whether or not PrEP was actually for them and would be something that would actually benefit them or fit into their lives. And that was actually a great process as well. And if that training initially was 8 hours, and now it's actually 4 hours, and you could kind of feel just from, we took out the role plays because people seem to have a lot more understanding, at least within our community, about what PrEP is. And if people are interested in that training, we're more than willing to send it out to folks if people would like a copy of it and would like to take it and make it their own. So we're more than willing to share that. And then we basically added PrEP to our evaluation web process. Luther Consulting was actually really generous with the fact that we were able to add 4 assessment questions, whether or not people had heard of PrEP and whether they were on it and whether they'd been on it in the last 12 months. And then if they had been on it, where were they accessing it? So, and that information has actually been really good, kind of a benchmarker to see how successful we're moving with regards to getting it out there. Anecdotally, about 70% of the folks have heard of PrEP that we're accessing, and about 25% have taken it in the last 12 months. And then provider education, which kind of goes back over the other houses. A lot of the training kind of talked to clients about how would they interact with their medical provider around the conversation of whether or not PrEP would be good for them, because we were hearing a lot of pushback that people had talked to their doctor and their doctor basically wasn't clear on how to handle that conversation. So we want to make sure that the providers that these individuals we were referring to were able to have a culturally competent and appropriate interaction with that client with regards to them getting themselves on PrEP. And then we're basically integrated. So we've worked our training now into our certification process for HIV test counselors. So now everybody who goes through our certification process, which is a 4-day training, also receives the training on PrEP within that. So it's now completely woven in. So next slide. All right, so this is an overview of, so basically individuals do outreach, someone accesses PrEP or a test, and then within that, the HIV test counselor has a conversation about and the assessment of whether or not PrEP conversation is right for that individual. And then if it is, information is given to that person. If they, how to talk to providers and everything that I just mentioned a minute ago. If for some reason there seems to be additional barriers or a client needs additional information, we can actually refer somebody to a PrEP navigator, and that navigator can help them work through even other barriers that might be preventing them from accessing PrEP, or where to go and all those other things. I mean, the important thing here is if you're actually doing high impact HIV prevention, starting at the top, the people that you're testing should actually be the same people that would be a good candidate for PrEP. So it kind of folds nicely into if you're reaching who you need to be reaching, you should also be reaching the same people who actually need to be PrEP. So that being said, so when we started this conversation, there was a lot of confusion around whether or not PrEP was kind of happening within the agency that we were talking about, or if somebody actually had to be referred out to a medical provider. So this is kind of just the visual with regards to the fact that it's kind of all under one roof. So these are obviously ideal, and if a client feels comfortable accessing an HIV test, that particular agency is culturally competent or has the savviness to actually provide them with PrEP and have those conversations around whether or not PrEP's appropriate for somebody. So, so the next slide kind of shows when somebody is, so if somebody actually has to be referred out to their medical provider. So some of our community-based organizations don't have the medical infrastructure to actually offer PrEP within house. So this kind of relies a little bit more on the test counselor to have that conversation and do what they can to actually help navigate that individual to accessing PrEP with a medical provider that can actually write the prescription. So next. So depending on whether the setting is, it kind of impacts what kind of test that individual can run. Obviously, if it's a more medical setting, they have more access to lab testing, and if it's a community-based organization, rapid testing is more likely to be appropriate. So I thought these next 4 slides were actually really helpful. I attended the HIV Diagnostics Conference in Atlanta this year, and Dr. Randall did a really good assessment of what kind of HIV testing was happening out in the field. And what she did is she actually looked at a number of 52 different health jurisdictions and kind of asked them the following questions. So what kind of samples were they gathering for their HIV testing? And you can kind of see that there was a lot of rapid HIV testing with blood happening in the field. So I thought that was a really helpful. This visual for me was like, okay, this is really helpful. And then the next slide kind of shows the fact that the rapid testing is actually increasing as years go by, and with regards to, it looks like the standard lab-based testing is kind of steady for the most part, but rapid testing is definitely out there. And, no, go for it. Oliver's rushing me along, which is fine. So this is a quick visual just to look at sensitivity, specificity, what generation, and then the runtime. Each of these tests, these are the 7 different tests that are currently CLIA waived on the U.S. market. They all have their strengths and weaknesses with regards to where they fit and how they fit, and the pricing is on the bottom as well. That's the public health price. So there's a degree of diversity out there with regards to these tests, and if anybody ever has any questions about why we use which test and where, I'd be more than willing to have that conversation with folks. Or if you're actually looking to change whatever particular testing technology you're currently using, can help with that conversation.
So I'm going to chime in. This is Oliver again. I'm going to chime in briefly after Thomas's awesome description of integrating PrEP into HIV testing to talk about what would be the ideal test for HIV in the context of PrEP. It should be easy to use. It should have low quality assurance needs. It should be cheap. It should crucially miss very few true positives, and it should detect very few false positives. In other words, it has to be a reliable test. I think for PrEP, the challenge is really going to be to develop a rapid testing strategy that finds acute HIV as early as possible in settings where lab-based 4th generation and RNA testing are not readily available, because we don't want to restrict PrEP to places that can only do a 4th gen test or an RNA test. That would really hamper, I think, the public health effectiveness of PrEP as an HIV prevention technology. So there's no right answer to this. If you only have rapid testing available, what should you do? I think one possibility is to repeat the rapid test soon after PrEP initiation to catch the people who actually actually had early HIV infection at the time they were first tested. We don't know what the proper interval for that is. Is it 2 weeks after they start PrEP? Is it 4 weeks after they stop PrEP? We don't know if this actually prevents resistance. We need data on this. I would say, and this is, again, this is me talking, this is not the Department of Public Health in San Francisco talking or the CDC talking. If I were somehow in a setting where all that was available to me was rapid HIV testing, I would probably repeat the rapid HIV test pretty soon after they start PrEP to make sure that we were catching acute HIV infection as quickly as possible, meaning as quickly as possible after the antibody actually turns positive. In other settings, however, if you have access to RNA testing or increasingly the 4th generation antigen antibody test, the lab-based test, that's the one to use to reduce the risk of acute HIV infection starting PrEP. So I'm going to turn it over to Melissa Morrison, who's going to talk about integrating PrEP into a social network testing strategy in Tennessee.
Thank you. Good afternoon. So I'm going to start out and just tell you a little bit for just a minute about our demographics, because they don't let me do a presentation without showing this next slide. Just showing you how things look a little different in Tennessee than they might in San Francisco or in Houston, but maybe similar to some of your jurisdictions where you are. And just these 3 arrows are what I wanted to point out, that the majority of our cases are in males, they're in non-Hispanic African Americans, in MSM, and increasingly in young folks between the ages of 15 and 34. And so when we think about any changes we want to make in Tennessee, we always want to take that into consideration. And so on the next slide, this also just shows you, I'm going to talk a little bit about social network strategy, and the 2 arrows are pointing toward the county labeled number 7, which is where Nashville is in Davidson County, and the county labeled number 12, which is Shelby County, where Memphis is. And that's where 2/3 of our new infections are in our state. And then the other 93 counties have about 1/3 of our new infections. So we really try to target things in those 2 areas whenever we roll something out as well. So on the next page, this is just a summary of what our current testing program looks like. So before we started thinking about how does PrEP fit into what we're doing in testing in our state, I think this is really helpful to take a look at. For those of you that are part of health departments, you'll be really familiar with Category A versus Category B. And those of you that aren't, it's not that important. But anyway, it's always CDC kind of looks at how we're doing our testing and what's expanded and what's not. But so in our state, we're doing about 120,000 HIV tests a year, which is quite a bit for a state our size. And we found 462 new positives through that testing. And that's about 63% last year of all of our new positives, which was the highest amount we've had in quite a while. As you can see with our linked to care percentages, we're not quite where we want to be with 80% linkage within 90 days, and we're certainly having to kick it into high gear to try to get to 85% linkage in 30 days, which are our new goals. So, but we are finding a lot more folks than this are actually getting linked. It's just perhaps not within the 90 days that this was measuring, and sometimes when we do reporting, we're outside of that. We still have time for people to get linked, and we didn't get to count them. But we're getting close to 80% in most of our testing. The thing about this is, and I didn't split this out because I didn't want to bore you guys, but we are doing a variety of test technology. About 70,000 of those tests, most of our health department tests, are 4th generation Bio-Rad tests run in the lab, and we did find somewhere in the neighborhood of 13 acute cases per year since we've been doing that. We started in 2013. So the 4th generation tests are great, and it's great when we can get those tests happening, but not all of them were able to do that. We're still doing some point-of-care oral testing with rapid tests. Part of the reason why is in jails, we aren't allowed to bring sharps in, so we can't do even finger stick testing in some of our jails that we're doing high volume testing. In other places, we have CBOs that haven't gotten to the point where they're able to do, especially not blood draws, but they're still having some difficulty with insurance issues and with being able to do finger sticks. So, so we are doing about, I'd say about 40,000 of those tests are point-of-care oral. There are a few that are point and care finger stick. And we have a variety of partners that are contributing to this 120,000 tests. You know, we have health departments, we have STD standalone clinics in 6 of our counties. We have ERs, we have corrections in both jails and prisons, we have CBOs doing outreach testing, and we have FQHCs who are contributing to those numbers. So in taking a look at that, we've come up with 2 strategies in our state to incorporate PrEP into our testing program. And the first one I'm going to talk about is the social network strategy. And on the next slide, you'll see a little bit more about what that piece of testing looked like. And so now, you know, the first black circle, the 1,953 tests, you'll see that's not a huge number compared to the 120,000 we're doing in our state. However, it's been a really significant program for us through CAPAS because we have had the highest positivity rate we've had out of this is 13.3% positivity. This is testing in young black MSM in Memphis, which is our highest seropositivity jurisdiction in the state. So it's been extremely successful for us. We've managed to, with very little money and investment, identify 71 new infections over this about, it says 4 years, but because everything wasn't a full year, it's about 2.5 years of work. You know, 71 new infections with a overall positivity rate of 8.7% was pretty successful for us. We really struggled to hit 1% and 2% positivity for CDC's threshold, so this was a pretty big deal for us. And so we really wanted to take a look at, you know, we have targeted in on 1,953 young black MSM in this area, in both Memphis and Nashville, that we think most of these guys would be eligible for PrEP, and so we've tried to think about how can we use this testing strategy that was coming to an end because CAPAS was ending and incorporate PrEP into that. I will say one thing I want to point out is that this was over 3 different community-based organizations, and one of them did have the ability to draw blood, and we worked out an agreement with them to be able to send blood samples to our health department in very high-risk folks so that we could perform 4th-generation testing and try to find acute cases. And the other 2 agencies were not able to do that, but we're still trying to work with them and problem solve on ways they can make that happen. So if you go to the next slide, integrating PrEP referrals into social network strategy, what we've done, and this has just begun actually last month, is that 2 agencies that were doing the majority of this testing in Memphis are going back through all their previously tested HIV negative young black MSM, and they're recontacting them using the same social network strategy model that CDC prescribes. And the idea is that you pay them, you give them not pay them, I'm sorry, I used the wrong word. Well, you give them an incentive to reimburse them for their time for coming back in and receiving another HIV test and receiving some education and counseling around PrEP. And so our social network strategy specialists are recontacting each of those 1,900 guys and asking, not all at once, we're going to do it over the period of a few months, but asking them to come back in and get an HIV test. And they'll get the same $20 incentive that they received when they first did this sometime in the last 3 years. And then they'll get some education, and we'll talk to them about PrEP. And if they're interested and still at risk and still negative, then those clients will be referred to a PrEP navigator for next steps. And ideally, that's going to happen within the same agency. We're working on getting PrEP navigators placed at each of those agencies. And again, you know, in one of those agencies, it's going to be they're going to be able to draw blood and get a 4th-generation test, and the other agency, we're still working on that. It's more than likely going to be an oral fluid test. But if somebody is at very high risk that perhaps had a recent exposure, we're going to try to get them into the health department to get that 4th-generation test. The other slide I wanted to show you here around STD clinics, we are also looking at, without any additional money, which I know a lot of you guys may be in the same boat thinking, I don't have any funding for PrEP, and no one's, you know, handing us extra dollars to be able to do these referrals, so how will this work? What we've done in our STD clinics, we've just finished rolling out training for all of our DIS across the state, and letting them, you know, I think very similar to what Thomas was saying, it's about, we started out with a longer training, we ended up going down to about 4 hours, and we went through and trained all the DIS on how to give PrEP referrals, and we've given them access to our provider directory, which is not probably as extensive as San Francisco's might be, but we do have about 25 providers in our state who are willing to provide PrEP. And so the DIS have accessed all of that. We've actually pre-printed them some referral cards so that they can hand those to patients, put the name and number of their provider that they've chosen to make an appointment. And they can walk out of the health department with some information about PrEP and an appointment to get PrEP, even though we aren't at a place now where we can provide that. And we've given, to keep it reasonable for our DIS, because we don't have the funds to be able to provide specific DIS devoted just for PrEP, we've asked them to target 5 categories of folks that come into the STD clinics. And this is any male or transgender client that has a positive syphilis but is HIV negative, a positive rectal swab for gonorrhea or chlamydia but is HIV negative, any male or transgender partner of a male or transgender STD case, and any male or transgender who answers anal sex equals yes on their interview record or IDU equals yes. So for the most part, when we add all that up for all of our DIS across the state, it's no more than about 50 to 70 people per year that we're asking them to target for PrEP referrals, but we do have 60 DIS across the state, so that's going to add up to a pretty significant amount of counseling and referral that will happen as a part of their regular job. And so I put in a couple extra slides about risk assessment here because there's been a lot of talk for us about that, and we're still working on how we're going to get our CBO staff to assess risk before they make the referral onto the provider. This is the tool from the CDC 2014 Clinical Provider Supplement that was released, and this is a score that you add up depending on how you answer these 6 questions. And if the score is 10 or greater, then they're evaluated for PrEP, and if not, they just get standard HIV prevention risk reduction services. And then the other thing I included here, the next slide, is something we were pretty excited about. So I want to say, I hope that there's somebody from Ohio on the call. We were not able, this is not our app, we did not develop this in Tennessee, but we're very excited about what ARC Ohio has done with this because it's a great app, and we've been trying to get a hold of them and get permission for us to talk to who developed it, and we haven't been successful with that up to now. But there's some, when you go to the App Store for Apple, this is one of the few PrEP apps you can actually see and download, and they have a really great system set up, really simple touch screen where you can check all the statements that apply to you, and then you can go on to the next and be able to show, PrEP might be right for me, and then there's a list of what town you're in and what providers might be close to you. So we're looking to develop something like that as well, which might be the most expensive part of all of this that we've talked about, because up to this point we haven't spent very much money or had very much money to spend. But with something already put together, it's nice that you could take this and with permission be able to replicate it. It's a lot easier than trying to design something from scratch. So we were really impressed with what Ohio had done. And just to move on to data collection, we are trying to put our heads around, again, without a lot of money, how are we going to collect this information? And we've had some difficulty getting boxes added to PRISM to be able to collect whether we've done PrEP counseling in PRISM for our STD clinics. So we're having, until we can get that done, we're actually just having folks send us the PRISM ID numbers of those who get counseled, and we're going to keep track of them kind of the old-fashioned way. And we are working on setting up a REDCap database for collecting information from our community-based organizations that are part of 1506, which is our PrEP award in Memphis. So, and for those of you that aren't familiar with it, and if you're thinking about how to keep track of this, I'd encourage you to go to Project REDCap. It's actually been developed by Vanderbilt, but it's for use for free to community-based organizations and any nonprofits. And so we're going to be setting that up actually within the next month or so to keep track of how many folks we're identifying for PrEP counseling, how many folks are actually getting referred, how many are getting on to get a prescription, and then being followed up from there with some of our navigators. But it's very customizable and very secure, and it has mobile app availability as well, which is pretty exciting. And then the next slide is just sharing with you, what CDC has told us they're looking for as far as reporting elements go when it comes to PrEP referrals. So in both of these ways that we are going to be identifying folks and referring them to PrEP from our testing programs, from both social network strategy and from our clinics, this is the type of information, which is a nice start that CDC has given us for what they're looking for what we've done as part of the grant, and we're also going to extend that on for things we're doing that aren't part of the grant. But just looking at keeping track of the number screened, the number eligible, the number referred, linked, prescribed, provided adherence support, and provided navigation. And now, granted, everybody on this call may not have access to full-time staff in order to go as far as providing adherence support and navigation past the prescription period, but I think it's really important to try to collect as much of this information as possible, because we all want to know, where are people dropping off on this continuum? You know, what is it that is going to cause someone to not go on to a provider, or what's going to cause them to not get the prescription once they go to the provider, or to stay on it and be adherent after that. And so we want to try to document reasons why people drop off, so that we can develop down the road different mechanisms to try to intervene and support folks and get them as far down the road as we can. So that's all I have. And this last slide is just a picture of downtown Nashville.
Awesome. Thank you so much, Melissa. That was a totally inspiring example of how to integrate PrEP into what's a really, really interesting HIV testing program. I think the numbers you presented about new positives detected through your social network strategy made all of our hair stand on end.
Well, I love the angle with no money.
Yeah, and the angle with no money, exactly.
Where there's a will, there's a way.
Yeah, but incorporating social network strategies is just, it's so right on. So now we are going to turn it over to Megan Cannon from the Houston Health Department. Megan is going to talk about integration of PrEP into HIV prevention contracts.
Thank you, Oliver, and good morning or afternoon to everyone who's here on the webinar. Thanks for sticking it out thus far. Again, my name is Megan Cannon. I'm the PrEP coordinator here at the Houston Health Department, and I'll be talking about a slightly different strategy of how we're integrating PrEP into our HIV testing, particularly with our HIV prevention contractors. Next slide. Okay, and before I dive in, I wanted to kind of give some contextual background about the HIV and PrEP landscape in Houston/Harris County, which is the county that we sit in. And Harris County is the third most populous county in the United States. So what they say is true. Everything is indeed bigger in Texas. And we have an estimated 4 million residents who live in a very sprawled out 1,700 square miles. So in terms of scope, to explain how big Houston and Harris County is, you can fit about 36 San Franciscos just inside of Harris County. And in terms of what the HIV epidemic looks like here in Houston, our demographics are very similar to Tennessee in terms of who's getting impacted. So we have a high number of gay and bisexual men and other men who have sex with men who represent about 2/3 of our new diagnoses. And then we also have our African American youth are also highly impacted. Looking at the broader scale, Houston has the distinction of having the 11th highest HIV diagnosis rate in the country. Every year we have about 1,200 to 1,300 individuals who are diagnosed with HIV. And if you look at the map on the left-hand side, it just kind of gives a sneak peek of where that HIV incidence is happening. So clearly, a lot of our outreach efforts are located mostly in the central and northern parts of the city. I will mention we also rank in the top 10 for syphilis, chlamydia, and gonorrhea. So we're also seeing a lot of comorbidities, particularly with syphilis. And in terms of healthcare access, I want to put in a plug on kind of the number of uninsured we have in Houston. 1 in 4 residents don't have health insurance. And because you're a non-Medicaid expansion state, healthcare access is a big issue, which is a concern as we're trying to get people on PrEP who may want to access it. And then the last bullet point, from our latest MSM cycle reported through the National HIV Behavioral Surveillance Survey, only 3% of MSM reported using PrEP in the past year. So in terms of where the Houston community is in the PrEP conversation, we're very much at the beginning stages of just trying to make sure that people know that PrEP exists. Next slide. So in terms of our strategy of how we're trying to integrate PrEP, we are funded by the CDC through PS 12-1201, and we use this funding to subcontract with local community-based organizations to implement either counseling, testing, and referral, so HIV testing, or health education and risk reduction, or HER, in non-healthcare settings. And of the 7 contractors that we work with, 6 right now are funded to do counseling, testing, and referrals. And so with each agency, they have a target goal of the number of clients they're trying to reach within the contract year. And our testing outreach is primarily focused around MSM, transgender individuals, and communities of color. And in terms of the testing technology, the types of tests that people are using also vary depending on the setting that they're doing the testing at. So we use Determine and See, and then some other folks use OraQuick. In terms of our testing capacity, in the last year, our contractors tested over 6,000 clients and found an overall positivity rate of 3.4%, which is pretty good. And then, of course, for clients who are tested positive, we link them into care either with the agency that they tested or route them through the health department. And because the people we're trying to reach out to, oh, go back, sorry, I jumped to, not there yet. But in terms of integrating STI screenings and PrEP education, the people that we're trying to reach out for testing obviously are really good candidates for PrEP. So when integrating PrEP into our HIV testing strategy, we amended our contracts this year to add the deliverable that all our contractors who do CTR must provide PrEP and PEP education to all clients who come in for HIV testing, and then make referrals if the client is deemed eligible. Next slide. And so since we just started this strategy this year, here's a very small snapshot of how we're doing thus far. And to explain our data collection process, because that's still kind of in flux, we do not yet have PrEP education measures included in our eClips database, which feeds into eValWeb. So what we've been doing is asking our CBOs to fill out a separate PrEP data collection form, reporting on the number of clients who've received PrEP education and PrEP referrals. And so then we compared those numbers to the number of HIV tests that they actually reported doing for that particular month. So obviously, looking at this chart, we have some work to do in terms of either documenting, reporting, or providing PrEP education to our clients who are receiving HIV tests, because that's what we contracted our CBOs to do. And so we're looking at kind of figuring out why that drop-off is happening, and it's something we're trying to monitor and address at the moment. So next slide. And I will briefly mention, so the 12-1201 program has had a lot of successes despite the numbers that I just showed you. Because Houston is fairly new to the PrEP conversation, we feel like we've been really successful with offering capacity building assistance by providing PrEP training to the frontline staff of the CBOs who we're contracting with, and will continue to do so. We also have dedicated community liaisons to assign to each agency, so they help us with monitor contract compliance and addressing any issues or concerns that come up with the numbers that come out that are reported at the end of each month. And then in terms of the PrEP landscape, even though we are in the beginning stages of just trying to get people to know that PrEP even exists, there are a number of organizations that have been doing this PrEP work already. So we've been benefiting from that previous work. And then on that same token, one of our challenges is that not all of our organizations are as familiar with PrEP. And so we've been trying to address this issue with trying to make sure that everyone has the PrEP literacy skill set to talk to clients by providing tailored PrEP training. And then from a monitoring and evaluation perspective, this is where I think in hindsight this is something that we are currently working on to try to address, but something that we could have given more guidance on to our contractors on how to report these PrEP measures, since it's not currently already included in our ECLIPS database. And then in talking with our HIV prevention contractors, they've identified the need for more consumer materials, which we've addressed by giving them PrEP cards, and then also a citywide referral network, because one of the challenges that we're finding out, so for people who do know what PrEP is and are interested in getting on it, we're having the challenge of figuring out how to connect the dots between PrEP referrals and PrEP linkage. So if one of our HIV prevention contractors refers someone to a PrEP provider, we are still trying to figure out the process to ensure that that person actually does link with the provider that they've identified. And that's something that some organizations have navigators, some of them don't. So that's something that we're trying to troubleshoot on our end when providing assistance to those CBOs. Next slide. And I wanted to show our ECLIPS modifications that are in the process of rolling out, hopefully by the end of summer, if not next month. And so since we realized that monitoring and evaluation was something that we needed to address, and documentation in my head is probably something that might help with making sure that our contractors are reporting that PrEP education and PrEP referrals are happening. These are just sample questions that we're in the process of adding to our ECLIPS database. And so when a staff person is doing data entry on a client encounter on the risk assessment, we've added the questions on before today: had the client heard of PrEP? Was the PrEP education provided to the client? And then because we're interested in documenting the number of people who've received PrEP education, because we are also responsible, similar to what Melissa showed in the reporting table, that the CDC is interested in seeing how many people learn about PrEP. We want to make sure to capture that if the client's partner was present when the PrEP education was given as well. And then for anyone that answers no to any of the questions, there are drop-down menu options to help figure out why the education wasn't given. Next slide. Oh, and then in terms of the results section, so if someone's HIV test came back negative, they would have to answer the staff person on the back end would have to answer these questions asking about PrEP screening, eligibility, and referral. And then if the staff person answers no to any of these questions, again, there would be a drop-down menu saying why the client either wasn't eligible or why they weren't screened for PrEP in that encounter. Next slide. And then just to quickly recap, I talked about all this before, but pretty much the things that we are working on at the moment is figuring out the reasons for why we're seeing a drop-off in the reported number of PrEP education encounters, and seeing if there's either it's a protocol issue, figuring out if the modifications that we're making to our data collection system will help out, figuring out if it's a staff capacity issue. Obviously, I just showed you the modifications that we're making to ECLIPS, and then in terms of the other areas that we're working on is continuing to provide PrEP training, and then exploring if we can create a referral network, and then sharing materials out once we create a social marketing campaign. So in closing, thank you for listening to my presentation, and hopefully you learned some nuggets of what to do or what not to do with integrating PrEP education and referrals with your HIV testing. And I'll hand the webinar reins back to Oliver.
Thank you, Megan. That was terrific. I think the highlighting the need for, I mean, first of all, the fact that you guys are incorporating PrEP assessment into as many of your HIV testing contracts as possible is fantastic. And it also highlights the need for sort of the follow-on step, which is how do we put together effective PrEP navigation programs. And I will tell you from other activities that we're doing with other health departments around the country regarding PrEP, the need for figuring out the PrEP navigation program is really rising to the top of the list. That is it for our formal presentations, but we have about 20 minutes to tackle some questions, and these can be directed at anyone on the webinar panel. Some of you have already chimed in virtually with questions using the chat box. A couple of them I'm just going to start. Someone asked, what do you mean by acute HIV infection? All my learning thus far dealing with acute infections is that it means that the infection will leave the body on its own, like hepatitis A. Great question. To clarify, acute HIV infection is not like hepatitis A. It simply refers to the earliest stage of what is inevitably going to become a chronic established HIV infection. So once you have acute HIV infection, it's going to stay. It doesn't tend to go away.
I think you just, any HIV infection prior to antibody response, right, is how I would define it. So,
right. So this next question, I think, is for Thomas. The speaker just mentioned a few minutes ago a training they use for their outreach workers to educate them on PrEP. He stated they would share the training curriculum with the audience if requested. Please let me know how I can request a copy of this training for outreach workers.
Yeah, definitely. So if anybody's interested in that, my email is my full name, so Thomas, and then there's a dot between Thomas and Noble at sfdph.org. Yeah, no, I'm more than willing to share whatever training materials we have with regards to that, or even help have a conversation about what we've learned and some of the key components to that training. So yeah, no, whatever we've got, we're more than willing to share. So just send me an email and can easily make that happen.
Great. And so question for Melissa. In your algorithm for offering PrEP, which trans subpopulations are specifically referred to by TG? Does this include both trans women and trans men, or only one?
Well, we are working on doing a better job in our surveillance department and with our DIS on identifying transgender clients. At the moment, our entire PRISM database has about 40 transgender clients in it. So we have been very broad to say anybody that presents as transgender. We're also working on doing training with all the folks that interface with patients coming through our health departments to emphasize why it's so important to talk about sex at birth and then current gender as well, and to answer those questions and specifically ask every patient both of those questions. And we had some difficulty with that up until now. So we have been very general to say transgender, but we're only expecting for right now that might end up translating to 5 or 10 folks this year that people will see and talk to about PrEP. So we didn't want to exclude anybody by being more specific and saying male to female. But anyway, if we get to the point where our numbers are big enough that we need to, we were really trying to get that group of people down to a reasonable amount of folks that our DIS could work with, because some of them are doing TB and immunization and all these other things on top of HIV and STD as far as DIS goes. So we wanted to get it down to a reasonable amount of people that they wouldn't have a riot on us when we asked to add one more thing to their plate. So anyway, the short answer to your question is we did say just transgender folks in general.
Got it. Thank you, Melissa. So a question about the landscape in Houston. So Megan, Tarrant County Public Health, sorry, this is in Fort Worth, not Houston. Tarrant County Public Health in Fort Worth, Texas offers PrEP. We face barriers from primary care physicians refusing to refer insured patients to our clinics. Any strategies to overcome this issue? So Megan, have you also seen that in Houston? Is this on anyone's radar screen?
With providers not wanting to refer, I'm just trying, let me know if I'm getting the question correctly. So the question is, providers not wanting to refer to other PrEP providers?
Yes, that's what it sounds like. So it sounds like there's reluctance among primary care physicians refusing to refer insured patients to the public health clinic. And it's not clear exactly from the question whether it's reluctant to refer patients for PrEP period or whether it's a billing issue, that they don't want to lose potential revenue by referring patients they would otherwise give PrEP to public health PrEP clinics.
Got it. Yeah, I mean, so as a disclaimer, we at the Houston Health Department, we actually don't prescribe PrEP. We do, I mean, similar to our HIV prevention contractors, we provide education and referrals. We haven't seen, in terms of our provider outreach, we haven't heard of PCPs refusing to refer to a PrEP provider. Part of it could be a lot of our referrals are coming from people who are already doing HIV testing that we have contacts with. So we don't see a lot of barriers there. We just hired, I'm really excited, we just hired a new outreach specialist whose main job will be going out into the community to talk to primary care providers. So I think when that person starts going out to the community, he might encounter those, but I think a strategy to potentially address it, I mean, depending on the provider's resistance to referring out, it sounds like it's just a matter of doing technical assistance, of showing like, hey, if it matters of reimbursement, here are billing codes that you can use to potentially, you know, to get reimbursed back from whatever the insurance plan is. If it's a matter of protocol and like figuring out what tests you need, like I think that's a strategy that I would recommend with kind of trying to address that provider's concern if they didn't want to refer out to another provider.
Got it. So that's very helpful. So there are billing codes that can be used and can be provided to networks of potential PrEP providers. So I'm going to navigate this question to Melissa. How has PrEP promotion navigated the political environment in Tennessee, asking for states where the political environment may be hostile? You want to touch that one, Melissa?
Sure. Yes. I would first ask you to identify yourself as a legislator or not. So yes, it is absolutely a concern for us to set the stage for those of you not in the South. You know, I have had to field questions from our legislators about whether it's appropriate for health departments to hand out condoms or not, and they've questioned our condom contract in the past. You know, we certainly try to keep a low profile when it comes to HIV. And so having said that, one of the ways, you know, we do have as part of our 1506 grant that we'll be working with in Memphis, you know, we have a large campaign we'll be doing to increase awareness about PrEP for the overall community, for both targeted to both MSM and transgender communities, and we're doing that through subcontractors, so it will not be branded with the Tennessee Department of Health logo. I love, you know, that San Francisco has their beautiful logo with the Golden Gate Bridge on everything that they do, but we don't necessarily do that where we are. That's one of the ways we try to keep a lower profile, is by working through subcontractors. And, you know, so we have a lead agent, basically, that the money goes through, and then they hire the people who will do the work. You know, we did have to get legislative approval to accept the funding to work with PrEP in Memphis, and luckily the fiscal committee that approved that funding, we were a little concerned, but everything went through fine. You know, we certainly, I know if any of you guys watch late night television and you know, Colbert or Jon Stewart and things when they were on, they made fun of us a lot for our we had Don't Say Gay bills that they were introducing in our state, and we had, you know, lots of things that are not gay and transgender friendly. And so transgender bathroom bills have come up this session. And so, you know, it is a concern, but, you know, we've, of course, run everything in all of our projects through, you know, everybody here at the Department of Health and, you know, can back up anything that we're doing as far as data on how it can help save lives. And but for the most part, we keep a low profile by being able to work with contractors. So, you know, I will say that a lot of the things I just talked about are what our plans are, and we're just now starting to roll out. It works a little differently in Memphis and Nashville than it does in some of the more rural parts of our state. And luckily, that's where we need to be targeting, is in our larger cities, which is a little more liberal than the rest of our state. So I'll leave it at that.
Got it. Thank you, Melissa. And I know Thomas is itching to say something, and Megan, if you want to chime in too.
Yeah, we just rolled out a campaign, a social marketing campaign for trans women and men of color, and it had a lot of energy around it, and it wasn't even that sexy. But
when you say a lot of energy around it, what do you mean?
I'm trying to be kind, but people had some strong opinions about the imagery and just the concept of the campaign as a whole. So they had strong opinions, and it's if folks want to go to it, it's oursexualrevolution. I want to say .org. I'm not entirely sure, but it's fascinating how it brings out opinions, and I don't know what else to say about that. I'm sure everyone on the phone knows what I'm talking about, but here, even here in San Francisco, something that you would think would not create that much controversy actually did. But the campaign has actually been really well received among the populations that we're actually trying to reach. So that's the other interesting part of it. So it's culturally appropriate for who we are trying to access.
Great, thank you, Thomas. And Megan, you know, any issues you want to speak to about supporting PrEP in a Medicaid non-expansion state like Texas?
That is a good question. I was listening to Melissa when you were talking, and I was like, oh, yes, we also keep a low profile because, I mean, if everyone remembers back in the fall, the HERO initiative was happening in Houston, and part of the reason why we've been somewhat delayed in rolling out our program was we had to wait until the election season was over because we were told we were given advice to hold out until the dust had kind of cleared off when the HERO initiative was shut down to bring up our project and getting City Council to approve our PrEP funding. So, Melissa, when you were sharing your words, it very much resonated with me. In terms of working around PrEP promotion in a non-Medicaid expansion state, I think, especially for us, our priority is just hitting home PrEP education and trying to do outreach as strategically as possible in the spaces where we know that we need to be, especially given the high number of people who aren't insured. So a lot of the education initiatives that we're rolling out will be including an enrollment piece, just because we know that we'll probably be interacting with people who are underinsured or don't have insurance. So that's one of the main strategies that we're trying to address that particular issue.
Great, thank you, everyone. So just I'm going to add a little follow-on because a related question that came up in the chat box was, what about paying for PrEP, getting PrEP covered for non-insured people? And I think that's relevant everywhere. I think it's particularly relevant in Medicaid non-expansion states because many, many, many Medicaid programs will cover PrEP. And they'll cover, remember, PrEP is not just the pill, that's the most expensive part, but it's the pill and the visits and the lab costs. So what about if you are providing PrEP to, or wanting to provide PrEP to people who either are not eligible for Medicaid or live in a Medicaid non-expansion state, undocumented, or particularly undocumented people. So there are some crafty ways around this, and this is a little bit off topic for HIV testing PrEP, but it's such an important question. It comes up all the time. So in terms of getting the cost of the drug paid for, if you can document that someone is not eligible for Medicaid and is not insured, but makes under 500% of the federal poverty limit, you can apply that person to the Gilead Medication Assistance Program, which will pay for the cost of Truvada and have it delivered to them at home or a pharmacy or a clinic. What it won't pay for is the cost of the visits and the cost of the labs. So if you can find another way to cover visit costs and lab costs, then the Gilead Patient Assistance Program, or Medication Assistance Program, will cover the cost of the drug itself. Many questions about will the webinar slides be available? Yes, we will post them just as soon as they've been given final CDC clearance on the website. So yes, since we whipped through the slides, you will have a chance to read them at your leisure. And many questions about whether, Thomas, the training slides that you mentioned will be made available. And
definitely, and the social marketing campaign I spoke of as well, if folks have questions about how that rolled out and lessons learned, we're more than willing to share that as well. The condom message within our marketing campaign was challenging to negotiate with regards to the fact that syphilis is such an issue among populations that we're trying to reach, i.e. gay and bisexual men. So, and we can talk, I can easily share with folks how we navigated those waters and how we ended up where we ended up. So just to help folks not reinvent some wheels out there, they're more than welcome to have ours.
okay, I'm scrolling through the questions. How to deal with drug resistance with a false negative, HIV negative PrEP client. Okay, I'll tackle this one. So the issue here is that if someone who has acute antibody negative HIV infection starts taking Truvada, we know that those people are at risk for the development of HIV resistance mutations by their virus. So those viruses can become resistant to one or more of the two drugs in Truvada. So how do you deal with that? So first of all, this is a very rare occurrence, which is a good thing. Secondly, whenever anyone is diagnosed with HIV before they go on therapy, they have one of the many blood tests they have is called a genotypic resistance test to see what if there are any drugs that their virus may not respond to. So using that information to help construct an antiretroviral cocktail that we know will work for someone is really important. And I want to reiterate that it is almost always always possible to find a drug combination that will suppress someone's virus, even if they have a small amount of drug resistance due to having started PrEP while they had acute infection. I don't personally know of any cases in which that has not been possible. Thankfully, the occasions for having to do that are very few, and it really highlights the need to rule out acute HIV infection before starting PrEP whenever possible, and as quickly as possible after starting PrEP if that has unfortunately occurred. Let's see, going through questions. Lots of questions about access to the slides and training materials, and the answer to those is yes. And questions about assistance for undocumented clients who are interested in PrEP and PEP. Yes, I think using the Gilead Patient Assistance Program is a way to get drug, but again, does not provide for visits and lab tests. So, oh, here's one. So, is anyone offering PrEP to youth? studies that led to the FDA licensing PrEP for prevention, Truvada for prevention, were all performed in adults. So that means that officially Truvada for HIV prevention, or PrEP, is only package insert approved for use in those who are 18 and older. Having said that, we all know that there are many youth younger than 18 who are at extremely high risk for HIV infection. MSM youth, particularly young MSM of color, and PrEP is definitely being used in youth under 18 in adolescent medicine clinics. There are 2 studies of Truvada for prevention at adolescents run by the NIH that have recently wrapped up and are starting to release their findings. And the bottom line is that PrEP is safe and effective in youth under 18 years old. There are important adherence issues with youth. Youth tend to be less adherent than adults to their PrEP, and it looks like having more frequent visits to the PrEP provider, i.e. monthly instead of quarterly, improves the adherence, is associated with higher levels of adherence to PrEP among youth. There are important issues about can youth consent to Truvada for PrEP without their parents knowing about it, and that's very much a state-by-state question. I will say that here in the state of California, there is a provision for youth to get STD prevention services, including treatment for prevention, without their parents knowing, but that's very much a state-by-state issue. But the answer
Oliver,
is
can
yes.
I chime in about that as well when you have a second?
Yeah.
Sorry, I didn't mean to interrupt you. Believe it or not, actually, in Tennessee as well, we from a state perspective, asked our general counsel, who reports to the Attorney General, for an opinion about that. Rather than trying to remake any laws or establish any laws in our political environment, we, especially considering that we have St. Jude here in our state, who does a lot of clinical trials. They're in fact about to do an injectable PrEP clinical trial for youth under 23, between 13 and 23. So we were all very interested in the answer to that question, and we got our general counsel to give us an opinion. They reviewed our current laws, which sound like they're very similar to California's as far as allowing minors to be able to be treated for an STD without parental permission, and they gave us the opinion that they felt like PrEP would fall under that as a treatment for an STD, even though it's a pre-exposure prophylaxis. And we have that opinion on file here at our office, and we have brought it out in quite a few situations where we have partners who are interested in being able to work with minors but are a little worried about the legality of that. And so it's been very helpful. So I would suggest to any states, if you're at the state level and you're thinking about where to start and what to pursue, I would say, instead of looking at it, trying to establish a new law or to add something on legally, start with your Attorney General's office and see if you can get a legal opinion about what currently exists and whether PrEP could fall under that.
That's great advice. Melissa, that's fantastic advice. So we are, on that note, we're going to wrap things up. I will let you know that we're going to have another PrEP webinar in our series explicitly dealing with adolescents and PrEP, and that will be in early 2017. But stay tuned for that. And finally, if you're interested in more information on HIV testing and PrEP following on from this webinar, sign up for office hours. They will be on August the 11th from 10 a.m. to 1 p.m. Pacific time. You can sign up at www.getsfcba.org/events for a 30-minute slot to chat with Thomas or me about HIV testing strategies, incorporating PrEP referrals into your testing program, for any questions about the different HIV tests, and anything else PrEP related. So with that, I'd like to really, really thank our panelists who were amazing, and thank the audience for your great questions, and thank Mehrose Baig, our communications maven, for making this all possible. And that's it. So thanks, everyone, and enjoy the rest of your Monday.